Thanks for your email, Representative Sherwood. Now I'll have something to read later.
Mr. Chairman, we are live.
All right. Well, I expect that the good senator will be along shortly. But in the meantime, welcome back. This is the Subcommittee on Wyoming Department of Health and Budget. And our next topic, the 1 o'clock topic, is Wyoming Department of Health exception requests for those who might possibly be unaware. We put together a budget during the last session, and that budget was derailed and never passed. And so the section here is just to determine what happened to you guys, what became of that, and where do we stand. Representative Sherwood, if you needed to speak, please do, but you're muted. Fair enough. So, Director, that's back in your court.
Thank you, Mr. Chairman. Again, Stefan Johansson with the Department of Health. It can be relatively brief, but as always, happy to answer any questions. So as you mentioned, the last session was to set the supplemental budget. So not the standard budget, but the supplemental budget for all agencies, and in this case, Department of Health. We made supplemental requests totaling approximately $14.1 million in state general funds, $4.4 million in federal funds, and about $100,000 in other funds across a few select categories. Again, being a supplemental budget, these are really things that were coming up as emergent or unexpected, or items that were carried over, either from previous legislative discussions or the previous interim period. And I'll go through those. But as you mentioned, Mr. Chairman, ultimately there was a version of the Department of Health budget that passed both floors in the House and Senate, but was ultimately not reconciled by both chambers. And so there was no supplemental budget bill that passed this year, which essentially reverted us back to the standard 25-26 budget that was struck in the legislative session during 2024. So essentially, without overcomplicating it, we essentially went back to the budget that we had prior to the supplemental session, the standard budget for the biennium. But as was requested, we'll go through these exception requests and per the discussion that we had in Casper at your first meeting, kind of give you a sense of what has transpired in those categories and those areas since the failure of the budget, any contingency plans that we put in place to bridge the gap between the last session and the upcoming session in February of 2026. And then I believe it was requested anything that we could tease for the budget proposal that will come out, which won't be a lot, but can certainly speak at the high level, at the conceptual level of what items from our supplemental request are likely to carry over into items that this committee, the Joint Appropriations Committee, will see at our budget hearing in December, and then certainly in the session in 2026. If that's okay, Mr. Chairman, I'll go ahead and dive right in. Okay, very good. So just by way of introduction, as I mentioned, a little bit more than $14 million requested in general funds, state general funds for the Department of Health supplemental budget this past year. Out of that, again, kind of collapsing these into more understandable categories, 11.8 million of that $14 million was what we call required requests, things that we are compelled to bring to the legislature. So those are things like the developmental preschool external cost adjustment and child count. Those are statutory obligations that we have to bring in our budget request to the Appropriations Committee. The governor and the committee and the legislature writ large certainly have options with what to approve in those required requests or if to approve them, but we are, as a department, are required to bring them. So the vast majority of our requests this past session was in that category of things that we believe we are required to bring, either because it's law, we have to per statute, or in other cases, items that we don't have much control over. And you'll see those year after year, especially in Medicaid, where we get essentially invoices or bills from the federal government that we don't have much management authority or control over, and must bring those to the legislature for consideration. But going into the actual budget book, so on page 10 of the supplemental request, I'm not sure if you all have that in front of you. It's okay if you don't. This is relatively brief. There's only 2 pages or so of requests in the table. The first one that was listed, it was our first priority, was around Medicaid reimbursement rates for maternity care. And as the JAC and certainly the Joint Labor Health Committee have discussed over the past 2 to 3 years, maternity care, OBGYN care, labor and delivery care has been of concern for the state, especially its sustainability going forward, with several providers and hospitals over the past 5 or 6 years having made the decision to discontinue OB and maternity care services. A few examples of that are Kemmerer, Rollins, Evanston more recently, and Wheatland even more recently, where we've seen announcements of the discontinuation of labor and delivery and OB services. Accordingly, kind of on the back end of about 1.5 years of discussion at the Labor Health Committee, a lot of policy options discussed, we put a request in our budget for approximately $2.4 million, half of which is state funds, half of which is federal funds, to increase our Medicaid reimbursement rates, targeting what we call 105% of Medicare. And what we mean by that is Medicare costs in terms of how we determine a lot of Medicaid rates is kind of our upper limit on what we consider cost coverage. So we were targeting essentially 105% of cost coverage to mostly sustain the OB, maternity care, labor and delivery services that currently exist. Again, it was heavily discussed at the Appropriations Committee, heavily discussed on both chambers in the House and the Senate. But ultimately, the final product, the final budget, was not agreed to and implemented. And so that request, all of these requests, will have ultimately failed. There's nothing that we have, nothing major we have done in the interim to, free up internal funding to make that request whole. But I did want to mention that a couple of these requests will interact or could interact with potential federal funds that could be coming to the state of Wyoming and the Department of Health, resulting from the One Big Beautiful Bill Act, which we'll talk about a little bit later. I know it's on the agenda today. But certain priority areas, we don't know exactly if Wyoming will receive an award or how that will be considered and approved by the federal government. But that will happen between November 5th and the end of December based on the application that we will submit. And hospital-based care, hospital finances, sustainability, OB care, emergency medical services, there's a few areas that we think the federal government could help the state transform some of our rural care, but also help sustain some of our rural care, which again we can talk about later. But just wanted to mention that there's a few moving parts here with what the JAC and the legislature might see in terms of the department's budget request going into the next session, and interacting with other opportunities that we might have with other funding sources outside of the general fund. And this could very well be one of them. But to answer the kind of fundamental question, the issue absolutely still persists. Services like hospital-based labor and delivery, OBGYN, and maternity care, similar to the emergency department, ambulances with EMS services, Wyoming does have challenges with having high fixed cost services available given our low population, and scaling those services regionally or in the communities that we have throughout Wyoming is absolutely a challenge. And so this issue of the access to and the sustainability of OBGYN care and labor and delivery services continues and persists, and so will likely be a topic of discussion going into the next legislative session. The next request we made was kind of a holdover from 2024. We had done a study on Medicaid rates for behavioral health and kind of looked in a rebasing methodology of where we were paying below the cost of delivering the service, in some cases where we were paying above the cost of delivering services in this sort of rebasing methodology. That study was completed after the 2024 legislative session that set the standard budget for the 25-26 biennium. So we brought the results of that study back as a supplemental request. It was approximately $1.6 million, half of which is state general funds and half of which is federal funds. But the real idea was to rebase our behavioral health reimbursement rates in Medicaid. And again, both chambers, House and Senate, discussed that. I believe passed action favorable to it, but ultimately the final budget bill did not pass. We anticipate these discussions with behavioral health rates and Medicaid and kind of aligning with our broader behavioral health redesign outside of Medicaid will continue to be a discussion point going into our budget hearings this year and into the next legislative session. Next request, also in Medicaid, we had requested an additional position for our long-term care eligibility unit. The reason, which Chairman Pendergraft, I know you'll recall our conversations at JAC this interim and even prior, going back into 2024. We have a lot of volume coming in terms of long-term care applications in Medicaid. So folks who are applying for nursing home coverage or home and community-based waiver coverage, all of those eligibility applications, they do not get processed by our contracted customer service center. We process those in-house because they can be very complicated, these cases, the finances behind these cases, and we want to have state staff set up to review, provide customer service, and provide adjudication on eligibility for those. As we talked about previously, eligibility for long-term care in Wyoming Medicaid is pretty strict. The asset limit is $2,000, and that has not changed since, I believe, the 1980s, maybe even prior. But even with those strict eligibility standards, we still pay for approximately 65 to 70% of all nursing home bed days in Wyoming. So we're one of the biggest payers for long-term care because those services can be very expensive. And there's just a high level of demand given our aging population in Wyoming for that type of coverage. The reason we made this request is not, we don't make a habit of requesting positions, but in this case, we have had a lot of challenges in this unit just trying to keep up. And our average eligibility worker in this unit, it spiked in the last year to those folks working 700 cases in some instances. And we really want to target them working around 500 cases so that we don't, our customers, our elderly, their families don't experience delays, don't experience errors. Those things happen when the staff is overworked. And we actually met as a department through our Health Stat initiative, which we talked about earlier this morning, just last week on a deep dive into this problem because things are just stacking up and we are struggling to keep up. Part of that issue is very much a staffing level issue. So you will see an additional request going into our budget hearings in December and going into the legislative session. I think it's a dire need for the department because we do have a lot of folks who are in need of this coverage, and we need to process these eligibility applications as timely as possible. The nuts and bolts of it really, a lot of it comes down to the number of people we have available to work in that unit. We've got them working weekends, 50, 60-hour weeks, just to try to keep up with the backlog. But essentially what that results in is facilities like nursing homes, even hospitals, can experience delays in getting those eligibility applications processed. We like to keep our timelines to beneath 45 days, and ideally we'd be, hitting 15 days, 20-day targets for those applications, but we are not hitting that. Mr. Springer and his staff have done a really good job looking at internal process, things that we can do to speed that along, systems we can implement to minimize human error and track things better. But ultimately, I do think there's a very compelling case to make for staffing here, and so that will likely be a discussion point for the JAC and the legislature going into the next session. Next request, Mr. Chairman, was, next request, or priority number 4, was the per child amount and the external cost adjustment for the developmental preschools. Again, this is $11.7 million of the overall $14 million general fund request, so kind of the lion's share. This is one of those areas we are statutorily obligated to bring to the JAC. So as in every year, we will always have the updated figures, both for the ECA and the child count for the developmental preschools, and the JAC and the legislature will see that as part of our budget request. The next one, a little bit unique. This is in our public health division, a very small request to increase the funding for public health nursing salaries specific to our county-run offices or independent offices. There's 5 independent county-run public health departments that do not use state staff, they use county staff. And there was a bill 2 years ago that passed that required the department to bring as a budget request, bring to the JAC a budget request anytime there was state employee compensation changes. We have to bring a like request for the county-based public health nurses. Again, it's a statute that passed, and there was a slight change to state employee compensation about 1.5 years, 2 years ago. And so this statute requires us not to fund those county salary increases, but to bring that to the attention of the legislature for consideration. So I believe that will also be in our subsequent budget request. The next item was for an issue that we've seen over the past couple of years where home health agencies were declining to take additional high needs children in that are on Medicaid into their services, primarily because of how low our cost coverage was in Medicaid. So we had brought a request to the legislature for approximately $672,000, half of which is state funds, half of which is federal funds, to increase those reimbursement rates for home health. Again, primarily for high needs children. So skilled nursing services in the home for children who in many cases would have to be served at a higher level of care, like a children's hospital down in Denver. And so we had made that budget request. I'll hand that over to Mr. Springer. I know we made some emergency adjustments following last session, or had considered implementing those as a bridge to the next session, and I believe those are in effect. But I'll hand it over to Mr. Springer for any additional detail there.
Just curious, how many kids are we talking about on this? What's the population of these people?
Chairman Pendergraft, committee. So our home health under state plan, so we have home health in 2 places. We have it under the home ICU-based waivers, and that's really for maintenance of people if they need that type of care. And then we have home health on our state plan, which is our medical, and it can be used really by any individual, and it is used by some seniors, it is used by other people, but the primary user that drives our expenditure is high medical needs children. And so right now we have less than 5 children using this service, probably are more that could use it and are actually having to use hospital-based services because we've had trouble recruiting home health agencies to take these most difficult clients. And there were really two factors that were a big barrier. One was a policy change we needed to make to allow the home health agencies to use LPNs. We were requiring registered nurses, but we still require the registered nurse to go in and monitor the person on a regular basis. But then we allow, we've promulgated rules, and that's moving through the process to allow LPNs to also do that for Medicaid. This was allowed by scope of practice. We just hadn't caught up to scope of practice. So that was, a restraint that the home health agency sent us letters and asked us to do this. We evaluated it, and that was a good change. LPNs don't actually cost more. We pay less for it. So it's a great move for the home health agencies. It's a great move for the state. It gets the care out there. Then we looked at cost coverage, and it just had reached an emergency situation that not only the home health agencies were not taking new clients, a number of them had said we need to not serve the clients that we currently are serving. These rates really, we cannot pay our employees with what you're paying. And we were paying at the time about in the 40% range of Medicare. And so we've taken action to reduce other services that we found were paying over 100% of Medicare. And we've used those savings to increase the home health to 70% of Medicare, which is in our budget request, or was in our budget request. So when that did not pass, we considered that to be an emergency, because we really had children that were going to have services pulled from them within the next few months. So we were able to make a reduction of looking for any service really that was above 100% of Medicare, and taking a reduction on those services. So that was sufficient to pay for those services at least through the end of the biennium. We need to keep evaluating whether that's enough to pay for it permanently. We expect, as we increase the rate, that home health utilization will increase, because one reason it's been so low is because the rate's been so low. We've actually had trouble getting providers to take our clients with a reasonable rate, like that's 70% of Medicare, which is not 100% of Medicare, it's 70% of Medicare. We think that more of the services will take Medicaid children, and we'll be able to get more of the children home from institutional settings. So hopefully there's some savings there, but that it's very unclear whether what the utilization will be by the time the budget session comes. So those are the changes we made so far. It's funded within our budget, or at least we believe it is. We've cut something that had historical expenditures equivalent to the expenditure increase we expect, but it always can be a little bit messier in reality.
All right. Questions? Anybody? Okay.
Okay, thank you, Jesse. Mr. Chairman, the next three I'll kind of lump together.
Apologize. Sorry, I wasn't fast enough.
Okay.
I was just curious if there's an internal, let me say thank you so much for being able to pivot and address those 5 children, their needs. That is greatly appreciated. Thank you for that work internally. My question is internally, so there's a note here on home health services. The rates haven't been increased in more than a decade. Is there an internal process that triggers like, oh, it's been this long since we've adjusted a rate, and then you go and look at, where that's at in terms of private sector or inflation, or is that something you guys are doing annually? Thank you.
Mr. Chairman, that's a good question, Representative Sherwood. I'll let Jesse go into the details. Yes and no. So in some cases, we have statute or law that compels the department periodically to do rate rebasing. So think of your DD waivers. That's more of a structured process for rebasing. Nursing home rates, that's a very structured process that we actually recalculate annually for cost coverage. In other cases, no, there's nothing that requires us to do that. But Jesse and the folks at Medicaid do a good job using similar methodologies to make sure that we have our finger on the pulse of when we're getting really behind schedule of inflation or cost coverage. So we have the ability in similar methods to do those sort of actuarial analysis and see where we are. And so that's why we had the behavioral health rate rebasing request. That is not something we're required to do, but something that we started doing a little bit more proactively. And that's the reason you'll see, in certain circumstances in legislative session, the department bringing requests like that. So home health is one of them. Behavioral health is one of them. Years ago with our community choices waiver, which is home and community-based waiver services for long-term care, we did something similar to combine that with our DD our nursing home rate rebasing, because you can get 5, 10 years, even longer before these things are looked at. So we're trying to be more regular about it, but it's not something, to answer your question, that's internally triggered by a specific date or time, but something that we're trying to do more regularly. Jesse, feel free to weigh in.
Chairman Pendergraft, Representative Sherwood. We do an annual rate benchmarking report, so we compare ourselves to other Medicaid states in our region, just the surrounding states, plus Medicare, if the service is covered by Medicare. If we are able to get it, we also use private pay rates. So in some cases, there's national studies on private pay rates that include Wyoming, and we can reference those. And so those have triggered problems over the last few years, like the dental rates had slipped too far. And, a lot of Wyoming providers basically are okay. I don't want to speak for them, but they generally have been, we can't lose money on our Medicaid. We know we're not going to make money, but we can't lose money on it. And there's a breaking point where the different providers have communicated saying, hey, we're now losing money on Medicaid. Not just you're not just covering our basic costs. So we saw that with dental, and the department brought forward a request on that. I think on home health, it just had slipped way too far. So I think we just need to do a better job of adjusting that more regularly. I think when I see anything that's lower than 70% of Medicare, that really is a problem. So our methodology is not exactly the same as Medicare, but Medicare is a good barometer of cost. So most of Medicare methodologies are cost-based or close to cost. So when we're paying less than Medicare, in some cases we're paying less than cost, and for certain things, such as physical items, if we pay less than Medicare, the providers actually will not dispense the item or deliver the diaper or the adult diaper or any of those type of things, give the formula, because they're actually losing money on that item. So there's certain things we watch very closely, but I think home health, as a smaller service item, just hadn't been included in a lot of our process. I think we will just start to include it with our nursing home discussions. So when we bring nursing home discussions, we'll make sure we're highlighting home health and hospice. Hospice is actually reset annually by federal law. We're required by federal law to use a national hospice rate. So some of these rates are set every year, but others, due to just budget cuts and then other restrictions we've had, we just haven't adjusted them.
Thank you.
Back to you, Director.
Thank you, Mr. Chairman. The next three I'll lump together in our aging division, Unit 5002, 03, and 04. This is federal spending authority. We essentially have grant funding from Older Americans Act program for senior support services, senior nutrition services, and elder abuse and ombudsman services coming through federal grants. It's just federal spending authority that we need primarily to clean up and make more transparent the B11 process. So how we handle this now is through when those funds are needed and we need the spending authority, we would initiate a B11. And as you know, Mr. Chairman, and since you are all members of JAC, there has been an effort over the past couple of years to clean up the B11 processes when they are really becoming more standard, so that there's more transparency for the legislature, for the Appropriations Committee to consider that. So these three that total under 1.5 million, but there's three requests that we had brought in the supplemental session in those different areas is really to clean up B11 process, and you'll likely see requests like that in our next session. There's no general funds here; it's all just federal grant funding that's already been authorized, but the amount is more than the spending authority we have in the budget. So in order to clean up the B11s, we make a request for that. The next two, Mr. Chairman, these are combined between Healthcare Financing Administration and Director's Office Administration, where we were requesting to convert 5 AWAC technology positions in our Medicaid technology unit to permanent positions. Our struggle here has been the difficulty in retaining those employees, very technical type work, highly skilled when you think of system work, coding, vendor management, that type of thing. And with our AWAC positions, while we're grateful to have them, those positions in state government under contract, they do not receive, paid time off. It's a lower benefit structure, no retirement, different type of, lighter health insurance load. And since we can get, in many cases, 90% federal match for Medicaid technology work, we believe that it's prudent for the state to convert those to permanent positions and transition away from the AWACS. So that is something that we'll likely we'll continue to discuss that with the legislature, but that was the genesis of the request. The reason the director's office unit was involved there is years and years ago, long ago, we donated some positions when we were getting ready to modernize all of the Medicaid technology, which Jesse really took the bull by the horns over the last 10 years and got the state of Wyoming and Wyoming Medicaid to a point where we are extremely advanced with our systems, our claims processing, provider enrollment, data warehouse. We're a thought leader and we're a national leader in Medicaid technology. It's been very successful. One of the struggles has been you hire these AWAC very skilled positions, and quite frankly, they get poached by either the vendors that we're contracting with or by the federal government because they're so desired, and it's been difficult to keep that unit staffed up, which then requires us to turn around and pay $150 or $200 an hour for consulting services to get that accomplished. So more administrative nuance to these requests, but something that we'll continue to bring as a discussion point for the legislature. Similarly, the next request in the supplemental session was to move 12 part-time WIC positions. So this is in public health, women, infants, and children. These are field offices we have all over the state for, nutrition for new moms and infants. And we have part-time positions that we essentially need to and want to work full-time and would like to convert those. We don't need any funding for this. We have federal funding that can support it. And both chambers ended up supporting this request in their versions of the budget bill, but with the failure to reconcile through joint conference, this did not move forward. So again, will likely be a discussion point in the near future. And finally, last but not least, we had made a supplemental request for what we call the canteen fund at the Wyoming Life Resource Center. It was a $100,000 other fund request. It's a canteen that we operate, to provide snacks and meals at the Life Resource Center, but also for more vocational interaction, so clients can learn work skills, can work there. This, again, became a focal point in our budget hearing of why we would bring a request that wasn't an emergency. And I totally understand where that was coming from, but had neglected in my budget hearing to mention that this is also a B11 cleanup. So it was more administrative in nature of, the spending authority for the fund that we take these dollars from was handled over the years through B11, and the B11 cleanup does make that more transparent to the legislature. I'm not sure if this will be a request going forward. I believe we've figured out some other mechanisms to make sure that the funding was sound for this and likely do not need additional spending authority. Eric can correct me if I'm wrong on that, but that was the genesis of that supplemental request.
I will admit that one raised my eyebrows when I saw it.
And Mr. Chairman, that's totally fair. It's not something that I probably presented it as, hey, here's something new that we want, and neglected to mention it was more of an administrative cleanup on the B11 side. But the question is fair of what are we doing with those funds? Why are we doing it? And should that come up in the future, we'll absolutely have a better explanation for that.
Thank you.
And Mr. Chairman, that is the end of our budget request. Again, in the supplemental session, it was, a relative for the Department of Health's budget. Again, this is all relative, but for the Department of Health's budget, a relatively light request. I do think those issues related to maternity care cost coverage with certain, high cost populations like adolescent home health will continue to be policy issues for this committee and the broader legislature to consider. But not getting out ahead of my skis of the governor, I actually have my budget hearing with him tomorrow. And so as he considers the entire enterprise and the budget recommendations and budget that he will propose, in mid-November, I think we'll work through a lot of these issues and try to bring the legislature the best product we can, but also one that, recognizes the fiscal realities of the state. Always pleased, not trying to suck up here, but always pleased to work with my boss and his staff. It's very thoughtful and deliberative process with the Department of Health budget, and I think we've held true to some of the priorities that we've tried to establish over the past several years when it comes to behavioral health, suicide and suicide prevention, maternity care, some of these higher level items that Wyoming really struggles with. And I think we've made really good strides over the years in improving some of those. So that's my tease for the upcoming, budget proposal and budget session. But hopefully that was a good enough overview, but happy to answer any questions should you have them.
Yes, Representative Sherwood.
Thank you. I was quicker on the button that time. I think, again, just wanted to have a show of gratitude again over the collaborative process that you're doing with us and with the governor, knowing that there are some really key policy changes that could occur to help us better serve our constituents. And so thank you for that overview on your supplemental. Thank you for the pre-tease and that realizing the timeline is a little bit wonky, but I hope that you and your staff have a very productive conversation with the governor tomorrow, and I look forward to seeing that budget request in front of us.
Thank you, Representative. I too am anxious to see that. There's a lot of things going to happen over the next couple of months, that's for certain. So any other questions? Senator Larson? You happy?
Yep, I'm good.
Okay.
This is a lot to absorb, but again, thank you for presenting it to us again.
It is. We appreciate your going through that. I trust that if anything shocking comes out of your meeting with the governor tomorrow, you would give us a little bit of a heads up. I don't know what it would be, but
Mr. Chairman, I try to avoid shock as much as possible in this job. Shock and surprise is no good. I doubt that there's anything like that, but absolutely happy to keep this committee informed as we go forward.
I have reviewed the treat for shock first aid card in my wallet. I'm prepared to put my feet up. Representative Sherwood, you had your hand up for a sec.
Yes, thank you. I was going to say something silly about therapy puppies for everyone, but Too shocking. No, I was going to say, Senator Larson, I don't know how you've got your camera positioned, but there's times where your hand covers it and we can't see your lovely face.
Like there.
Which finger is that? So,
Sorry about that, but I'm moving the pages usually.
yeah. You must be working off an iPad or off of your phone.
Yeah, off my iPad. Yep.
Okay. Well, we'll continue to put up with it. At this point, is there any public comment either in the room or via internet?
Chairman Pendergraft, we have a public commenter in the room.
All right. Please have a seat. Tell us who you are, who you represent, and anything you'd like us to hear.
Thank you, Mr. Chairman. My name is Richard Garrett. I'm a member of the board of Healthy Wyoming, an organization that's devoted to better health outcomes for everyone in our beautiful state. It's a little odd to sit here and not see your smiling faces. By the way, I see, how many empty chairs are there? 7 or 8 empty chairs. So I'm going to do my best. And I sure appreciate your attention to this and to the work that you're doing to steward our state's budget and our fiscal responsibilities. I think your stewardship is extraordinary. I certainly appreciated the chair's observation that we need to avoid tripping over dimes and as we chase dollars. And Mr. Chairman, I also appreciated your comments about sustainability. I would like to add, though, that as we've heard from the department, that there's a lot of churn in participation in certain areas of the department's responsibility. And I feel confident that those who need help now with Wyoming's healthcare share that concern as well. But many need assistance now and can't wait for 5 years in order to prove out a sustainability model. Healthy Wyoming appreciates the Department of Health's management expertise, and I think that we've all seen strong evidence of that over the course of this day and back in Casper as well. But at the same time, I do need to, I hope this is appropriate, remark that Wyoming has, it seems, moved healthcare towards a heavy emphasis on analytics, what I'd call analytics. And I get that, numbers count. Our dollars have to be spent wisely. But it also coincides with the analytics revolutions in pro sports, especially baseball, football, and tennis. As you may or may not know, there are robots calling inbounds and out of bounds balls in tennis right now, and next year robots are going to be calling balls and strikes in baseball. Our hope at Healthy Wyoming is that Wyoming can keep the humanity in healthcare and use technology to find and expose the committee's goals of proving up waste, fraud, and abuse. And in closing, I just urge us all to remember a fundamental tenet of the Hippocratic Oath, and that is first, do no harm. We've got to be very careful about how we use our resources. There's no question about that. But we need to do no harm to our state's health and the people who depend upon all of us. And I know, Mr. Chairman, you have gone way beyond anybody's expectation for how you've helped people in your own community, in your own family. And I think that that's a wonderful model. We all in Wyoming want to be a part of that kind of model, and that's through the Department of Health and its mission for many of us. So thank you, and I'd be glad to stand for questions.
Thank you for your comments. I would point out that most people in Wyoming are a cousin of mine, so I'm going to have to lean toward them.
Well, they're good family members, I'd say, Mr. Chairman.
Thank you, sir. Committee, any questions, comments? Seeing none, thank you, sir, for your time.
Chairman Pendergraft, we have one person online who would like to public
All
comment.
right, please show them in. Welcome, ma'am. We would like to be able to see you as well if that's possible. Please introduce yourself, tell us who you represent, and anything you want us to hear.
Good afternoon, Mr. Chairman and members of the committee. My name is Dr. Kathy Emmons, and I'm the director of the Cheyenne-Laramie County Public Health in Cheyenne, Wyoming. Thank you for allowing me to share some comments with you this afternoon. I just wanted to briefly speak to item number 5 on the Department of Health's request for supplemental funding. And it's the $63,923 increase for some of the public health departments. And I just wanted to give you a couple of pieces of information on that. First of all, I want to make sure that everyone knows that public health is often the first line of defense in the community for health care. We are in all 23 counties. So, like I say, we're often the first line of defense when it comes to health. Secondly, several years ago, and to be really honest, I can't tell you how many years ago because it was before I got here. 5 counties went from being complete county or state employees to independent departments. And we're one of those departments. Our employees are all employees of our department, not the state. Our funding comes from a mix of different funding sources. But during that time when we did become independent, we maintained a contract for some nurses with the Department of Health. We pay a portion of the nurses, the Department of Health pays a portion of their salaries. Since I've been here, which will be 6 years next week, we have not received any increase in those salaries for those nurses. Even though the nurses at the state have gone up in salary, the positions that are funded with those dollars have not increased, which is why I believe that the legislature did pass that bill, and it's this legislative body actually, 2 years ago, that said that if there is an increase in those funds, those independent nurses would also, I shouldn't say the independent nurses, the counties would also get a portion of an increase as well for those specific nurses. So actually, we're just asking for that law to be upheld and to get those additional, that small amount. And I can't tell you exactly how many nurses. I know I have 5 in my department. And I think there's between 15 and 20 nurses. So it's not a large amount by any means across the state. But I just wanted to give you a little bit of background on that, just to kind of round out Director Johansson's excellent explanation of that. So I just wanted to share that with you folks, and I'm happy to answer any questions you may have.
Thank you. Any questions from the committee? I have one. Oh, go ahead. If you have one, go ahead first.
Apologize. So thank you, Kathy, for joining us today and for reminding us of, again, that bill, I think, was championed by Representative Tom Walters to address this very issue. And so now we have a gap in terms of a law that we've adopted that's on the books, but with the supplemental budget not passing, we're not meeting our obligation in that way. But again, thank you for testifying to this issue.
Mr. Chairman, through you to Representative Sherwood, thank you. I appreciate that.
Just a question, this is all very new to me. I'm a carpenter, so this is a whole new world. And drinking from the proverbial fire hose. But I've heard about nursing shortages and having to replace them with contract nurses. In your position, do you ever find that at your county level where you just don't have enough nurses when you have to go pay a premium to fill a gap? Has that been happening at all?
Mr. Chairman, Mr. Chairman, to you. During COVID, we obviously struggled with that issue. We are fortunate in Cheyenne that we have probably one of the broader or deeper workforce pools for healthcare in the state. So I've not had to hire temps or travelers. When I worked at the hospital, that was something we had to do, even here in Cheyenne, considerably. But we work really, really hard, and that's why this salary piece is really important. We work really hard to try to compete, excuse me, with the hospital, nursing homes, facilities like that, who can pay considerably more than we can pay. So I have to create the best environment I can to try to keep those folks so they don't become travelers. That's the bigger lure on our part, is for them to be pulled away into that traveling pool.
And do you have primarily LPNs? Do you also have some RNs? Is there a ratio there? What's the?
Mr. Chairman, no, we have only RNs. We do
Okay.
not employ any LPNs.
Thank you. Any other questions?
Mr.
Thank
Chairman,
you, ma'am. It's good to see you.
thank you.
Anyone else out there?
Mr. Chairman, no additional public comment.
All right. With that, we'll move on to our next agenda item, the one big, beautiful bill. I'm really anxious to hear what things from your perspective. I've been doing a little bit of digging myself and have received some information from other organizations, but I'm anxious, Director, to see what you have to say and what you're seeing from your angle.
Thank you, Mr. Chairman. Keep my comments kind of compartmentalized in a few different areas, and we'll close with what I think is maybe the biggest change or opportunity for the state in the Rural Health Transformation Program, which was part of that bill. But before we get there, I think it's relevant to discuss some of the impacts that other states are feeling that were in HR 1, or the Big Beautiful Bill Act, and maybe get some clarity out there, because not everybody lives and breathes and reads federal legislation. And so I think there has been some misunderstandings around the state of where Wyoming is impacted, where it isn't. And so obviously that bill has a lot of provisions far outside and unrelated to healthcare, health industry, Medicaid programs, et cetera. A lot of tax provisions, et cetera, which you do not want me to speak to. I am not an expert in those areas. But specific to the health provisions, there were a lot of changes in in what Congress was doing, making changes to state Medicaid programs. Pages and pages of different sections that have impacts for Medicaid programs, and I'll go through a few of them if it's helpful, and kind of mention whether there's an impact for the state of Wyoming's Medicaid program or not. So there were quite a few sections that did certain things to certain states based on how they're structured. So, the supplemental payment programs that we've been talking about, what some folks refer to as provider tax programs. We mentioned a few in our Casper meeting. We've mentioned a few today, where with hospitals, with nursing homes, ground ambulances, psychiatric residential treatment facilities, in Wyoming Medicaid, we have supplemental payment programs where we assess fees to those provider types. We collect that revenue and then match that revenue with federal funds, and then redistribute back out to the providers as a way of increasing cost coverage without having to increase rates and without having to appropriate or request state general funds. That's a federal allowance that every state has done, some states far more than others. And the HR 1, the Big Beautiful Bill, did did implement some caps and some restrictions on those provider tax programs. Largely, those restrictions and those reductions were directed at states that have expanded Medicaid under the Affordable Care Act, or who have varying kind of structures in their Medicaid programs through managed care arrangements, contracting out the management of their Medicaid programs to essentially private entities, private insurance companies. And those things are absolutely being curtailed by the Big Beautiful Bill, but Wyoming is not subject to those. As a non-expansion state, and as a state, quite frankly, where we have not, I'll just speak bluntly, we have not abused the supplemental payment or provider taxes. You have some states that benchmarked those cost coverage mechanisms at 200% of commercial insurance rates as opposed to Medicare. We have not. We've always been very fiscally conservative in bringing our legislature those requests. So we do not believe that those provisions will impact Wyoming Medicaid. Secondly, people have probably heard a lot about work requirements from the Big Beautiful Bill going into Medicaid programs. And that's true. It's known as the community engagement requirement that was legislated through the Big Beautiful Bill. And again, that impacts states who have expanded Medicaid under the Affordable Care Act, which Wyoming has not. So our populations, we do not have non-disabled childless adults that qualify for Wyoming Medicaid just purely based on financial eligibility criteria. As we've discussed with this committee, in Wyoming Medicaid, you must be both low income and meet one of our categorical eligibility criteria: age, blind, disabled, long-term care, et cetera. So we do not we do not think that the community engagement requirement will impact Wyoming, but we're certainly monitoring all of these things if that should change. But by the letter of the law and what's being implemented by the federal government through CMS, that's not something that we believe will impact Wyoming. There were some other provisions with the federal match rate related to Medicaid expansion states that have some reductions. Again, no impacts to Wyoming Medicaid there either. Somewhat outside of Medicaid and Department of Health's purview, it's been discussed quite a bit. There is a sunsetting and expiration of enhanced premium tax credits on the Affordable Care Act marketplace, so the Obamacare marketplace or exchange. In 2020, additional enhanced subsidies or premium tax credits were implemented at the federal level. And H.R. 1, the Big Beautiful Bill, does eliminate those, and that would be eliminated effective this year. So in the new plan year, starting in January, those subsidies would expire. That's not anything that the Department of Health manages or controls. We do not facilitate or run the Wyoming's marketplace. That is a federally facilitated marketplace. But we are monitoring that just from the public health and the insurance coverage perspective, because there is a chance if Congress does not act, or if there's not changes that are made to that, you could see additional people in Wyoming that may elect not to enroll in marketplace coverage. And so whether that's 10,000, 15,000, 20,000 people, could be upwards of 20,000 people that elect not to continue or renew that coverage because of the significant cost increase without that enhanced subsidy. And I should be clear and mention that the original subsidies from the ACA, from Obamacare, are not impacted here. So essentially what we'd be looking at is kind of going back to pre-2020, pre-2019 levels of coverage, and time will tell what that looks like. Again, we know the federal government is shut down right now, and there's a lot of discussion and negotiation going on there of what ultimately will happen with those enhanced premium tax credits or enhanced subsidies on the marketplace. But it's something that the Department of Health is certainly monitoring, something that we've heard a lot about in our public meetings related to the Rural Health Transformation Fund, of concern from the public of the cost of insurance, the cost of that health insurance going up significantly, and that could very well pan out to be the case. But like I mentioned, Mr. Chairman, it's not something that we have direct control over as your Department of Health. It's not specifically related to Medicaid outside of, the potential in certain cases where folks who, don't have coverage, conditions could get worse, ultimately long-term could need to be served by Medicaid programs. That's not a direct one-to-one correlation. So I don't want the committee to hear me say that 20,000 people go uninsured and therefore we have 20,000 people enrolling in Medicaid. Our structure and our eligibility criteria would really not be conducive to that, given that we're not an expansion state and our eligibility criteria are pretty strict here in Wyoming for Medicaid coverage. That is a few highlights from HR 1. I'll ask Jesse, Mr. Springer, if he has anything that I selected or elected not to mention. There's a lot of, hundreds, if not thousands of pages of HR 1 that are health related, but I picked some of the highlights. And again, in Wyoming Medicaid, we really feel like we're very minimally impacted by the big, beautiful bill in terms of Medicaid provisions. But we will discuss the Rural Health Transformation Program next, which is a pretty massive opportunity. But Jesse, anything I missed on HR 1 in general?
Chairman Pendergraft, committee. So there's a few provisions that we do find helpful operationally. So there's a streamlining of retro eligibility. So it's currently 90 days. We did look into that, and between 61 and 90 days, we had about $7,000 and very few people using that time period. But the bill extended retroactive eligibility to our CHIP population, which had always been kind of a challenge that some kids, about 4,500 kids, didn't have retro eligibility, but the rest of the Medicaid population did. So 60 days, it's not automatically offered. Individuals have to provide documentation that they would have been eligible in that retro period. So it's not a heavily used option, but if somebody's sitting in a hospital and needs care, it can be pretty helpful to have that retro period for a few people. So it's not a huge expenditure area, but it was helpful to us. The federal government's going to also enhance some of its processes for data matching, particularly on immigration status, which we were already doing, but they're planning some enhancements and some investments there on the federal systems.
Okay, hold on there just a second, because I may have a question or two. But before I do that, Representative Sherwood, do you have a question flirting around from before? Please.
Thank you. And if you're going to speak to this down the road, I can wait. But I was just wondering about the calculation to like the margin of error. I think I saw somewhere in terms of like an eligibility calculation or a clawback calculation. So if you could speak to that, or if you are later, I'll wait. Thank you.
Oh, perfect. I was going to get there, but I can get there now. Chairman Pendergraft, there's something called the payment error rate monitoring system. So we participate every 3 years, and the federal government essentially does a full audit with its contractors of both our eligibility error rate, and so that's eligibility determination errors, that the person was eligible in error, or there's different types of errors that there was some error on their case, but it didn't affect the actual eligibility determination, like typos and things like that. And then there's a claim processing error rate, which we are measured under the fee for service because we process our own claims. And so on the eligibility determination error rate, part of the reason we're asking for these positions is to make sure we are doing as good a job as possible to stay under that 3% error rate, which I think benefits the state just naturally because, individuals not being on, there's no expenditure there. So it likely pays for itself. But every percentage we're above that error rate, there is a possibility that we would lose that percentage of federal funds. If our error rate, in this example is 4% and they've set a 3%, they conceivably could claw back 1% of our federal funds, which is a huge amount of money, far exceeding the amount of money it takes to solve the issue.
Yeah.
In our most recent Perm, we haven't received our final rate, but we're close to the 3%. It might be 3.25%. We did have some chip air rate that was slightly higher because of that retroactive period, and different call takers have sometimes mistakenly given the retroactive period to chip, which is an error. So having as close as policy can be between Medicaid and CHIP and Medicaid and long-term care, that helps us improve our error rates.
Isn't there a 6% threshold where you're basically, you can stay under 6%, they don't hammer you too hard? It seems like I heard something about that, and I also heard that the last numbers I heard for Wyoming were right around the 5% range, which was still substantially better than a number of states. But can you speak to that?
Chairman Pendergraph, Representative Sherwood, there's no real grace period under the bill, so that the big beautiful bill did kind of erase all the kind of grace periods that are extended currently to say you might have an error rate, but you have been working on it. But the error rate is 3% in the big beautiful bill, not 6%. So we, anything we're above that 3%, we are concerned about trying to get our performance to be within the threshold we need. And it benefits us operationally as well. We don't want to make errors. Our claims processing error rate in the most recent cycle was less than 1%. So we're doing great there. It's actually a fraction of a percent. So our claims processing team, that entire group, has done an amazing job over the last 5-6 years. We've always had a very good claims processing rate, but with our new systems and the dedication of that staff, that error rate, if we find an error, we actually go back and reprocess all the claims to resolve the error. So we generally, if we're finding an error, we're resolving it and resolving all the claims that have that error, so we don't get found to have those type of errors.
Representative Sherwood, you had your hand up for a minute.
Thank you. I just want clarification on, is there a separate rate? So for eligibility, 3% or lower, and then no ding. And then for the claim processing rate, is it part of that 3%, or is there a separate percentage? I'm getting this all muddled, or is it combined?
Chairman Pendergraph, Representative Sherwood, there really are two rates. So there's an eligibility determination rate, and you could be dinged on that. And then you've put the people on the program, and we're assuming we've done it correctly, then have you processed and paid for things for them appropriately? So have you paid the correct rate? Did you follow your own policies and limits? Those sort of things. So that's what they're actually auditing us against, to say, did we follow our own state plan? Did we follow our own rules in paying these claims?
Mr. Chairman?
Yes, Ms. Martineau.
Elizabeth Martineau with LSO. I would know that the 6% error rate that you were thinking of, as well as the 5%, is for the SNAP food program, which is the Department of Family Services. They do have, in HR 1, the One Big Beautiful Bill, there was a new matching funds kind of level that they had set. Wyoming is at 5.12%, and the low end of that rate was below 6% to not have any issues with the SNAP program, I believe is what you're remembering.
Well, thank you. I know now that I'm not entirely wacky. You get so much of this information so fast that sometimes it's hard to keep it straight. But thank you for keeping me on the right track. I want to go back, if there are no further questions at this point. Mr. Springer, we started to talk about, I guess you would branch into the waste, fraud, and abuse section. I know that there are a number of states that have issues with people who are enrolled in multiple states simultaneously, and thought maybe you could speak to that from a Wyoming perspective. and also a number of persons who have gone on and are no more, deceased people still being on there. Can you speak to how often our rolls are examined and purged, and how that works?
Chairman Pendergraft, so we have a number of data matches. So our client services section, we've been investing in the Wyoming eligibility system. We call it WES. You might hear that acronym. So we have data matches with the federal government for Social Security, Homeland Security. We also have data matches with the Wyoming Vital Statistics Service for birth and death. So if someone dies, we are closing them as quickly as we are notified. Either they are closed either by Social Security in many cases that we get notified that that Social Security number has had a reported death, which sometimes is reported faster than even the death certificate, because those, they stop payments on the Social Security payments. We also get that from Vital Statistics. With the federal government, we have data matching for immigration. So we verify they're citizens and that those are valid Social Security numbers that match the identity characteristics that have been submitted. So not just that it's a valid Social Security number, but actually matches the person that's trying to use it. And so we just, on that, from an immigration standpoint, got a very short list of people that needed follow-up. Since this has been within the last month, we've started receiving a monthly report from the Trump administration on individuals that are, that they would like us to do more research from on immigration status. But I was very pleased to get our first report. And they did not screen out the non-citizen emergency services group, and we had less than 200 people that needed research. So I was very pleased about that. And then we run something called the SAVE interface, and that is where we are data matching with other states. They're using a data match that we provide to them to check if someone has overlapping enrollment between different states. And this was something that kind of accelerated during the public health emergency, but we would like to not have people be enrolled in multiple states. So if the way it should work is that everybody has one state of residence. And so when someone shows up on that interface, we send them letters to verify what is your true state of residence. And if they don't reply, we close their case. They're welcome to reapply, but if they've moved out of state, sometimes they'll ignore our notices, but we do close those cases. When we first ran that, we had 1,200 people. That's gone down dramatically since then. So again, we think that'll be a very small number. So every month now, we believe it's shrinking, and we'll hopefully be, within. There's always going to be some people that show on that list, but it shouldn't really ever be more than 100 or 200 people. And then we deal with it rapidly. We verify whether they actually are Wyoming resident. And if they are not, if they tell us they're not, we just close it on, very quickly. If they don't respond, then we close their case. And if they do, we just ask for some documentation.
You mentioned briefly at one point retroactive eligibility. Would you touch on that just a minute? I'm not sure that got explained very well.
So when any Chairman Pendergraft, when someone applies for Medicaid, they can ask for their eligibility to be made 1 or 2, and currently 3 months retroactively. They have to provide income, and if needed, assets, depending on the type of program. And that's usually that they've had an accident or something like that, and they actually were incapacitated and didn't apply while they were receiving care, so they're applying like a month or 2 after they started receiving care. So that allows people to get care retroactively. Right now, it's 90 days for Medicaid, 0 days for CHIP. So under OBA, which is what I like to call it. It's now 60 days for all the populations, which is easier for our staff to remember. It's one number. We did not have high utilization of the 61 to 90 days. Very, very few people, 1 or 2 people a year were using that. The easier fix is that the hospital could just apply when the person comes in with the information they have, and we could revise the app. And then retroactive eligibility doesn't even come into the situation. So we're just working with the different people that help people apply to just say, apply immediately instead of waiting till, the person wakes up, work with the family members to get an application in. And then retroactive eligibility doesn't really come into play.
All right, thank you. You were kind of on a roll before we distracted you with our questions. So
I think I was close to finishing. I'm sorry. I was going into the different data matches. You guys asked that question, so yeah. I think that was all I planned to go through, unless you have any questions.
I would like to say that this is something that I think we'll take up in a couple of weeks when we're talking about waste, fraud, and abuse. We'd like to know more about how these systems work, how you cross-check these data files, and how often that's done. One of the things that I also want to avoid is obviously the waste, fraud, abuse, where they're stealing money from people who actually do deserve or need these benefits. And we need to be able to minimize that. That is a big concern of mine. So we'll look at that intently in a couple of weeks. Director, go ahead.
Thank you, Mr. Chairman. 2 things there. As I mentioned before, more than happy, should that be an agenda item, to prepare whatever's most useful for the committee or have staff on hand to walk through process when it comes to our program integrity functions internal to the department, how we interact and work with the Attorney General's office on fraud, waste, and abuse. Absolutely welcome those discussions. The second thing, I have to mention this publicly. Jesse's being very bashful in terms of the performance of Wyoming Medicaid and his staff and his work in modernizing our data and technology infrastructure in Medicaid. This has been a Herculean lift for the better part of 10 years. But it's worth mentioning that the legislature, with 10% state funds, mostly 90% federal funds, years and years ago, directed us to invest in this modernization. And so many years passed that it's worth reminding folks of the fruit that we get to pick off of those trees and the dividends that pay to the state. We're ahead of the curve in many areas in Wyoming. Jesse mentioned a few of them, where some of the things that came from the big beautiful bill of what they want other states to be doing with data matches and verification on eligibility and payment, we have the technology infrastructure to be able to do that, by and large because of the good work of the Medicaid staff over the past 10 years or so in going through the painstaking work of designing and procuring all of these various modules to these systems. So it's something I think that the legislature and the state of Wyoming, you don't see it every day. It's a thankless job over there, but something that the state should be proud of in how we're able to implement some of these things that are coming at the federal level much easier than some other states who, frankly, just don't have the technology infrastructure that we do.
There's an old joke that talks about the problems we have in the United States, and the punchline is, at least we're not France. And I kind of feel that way, having recently met with a number of people from different states, and they're talking about the issues that they have. And yeah, we have issues. We're not perfect here, but at least we're not France. Is there anything we've left out? Mr. McVicker, would you like to weigh in on this, or?
Mr. Chairman, no, thank you. I'm good.
Well, that wasn't the question, sir, but so we've talked about the one big beautiful bill, and I don't know, from where I see, I don't see anybody online or in the room, but do we have anybody that wants to make a comment, any public comment from anybody.
And Mr. Chairman, just to note that if you are ready or if there's no public comment, happy to give an overview of the Rural Health Transformation Fund. We haven't discussed that yet.
Yes, I do have a note to that effect, and thank you for the reminder. I'm anxious to hear that perspective. But at this point, are there any questions on what we've covered so far?
Mr. Chairman, it does not look like you have public comment in the room or online at the moment.
Okay, so you guys have done such a terrific job of explaining things that nobody has questioned. So this rural health thing should be very interesting, and I have several questions, but please, sir, give us an introduction.
Thank you, Mr. Chairman. Again, I'll give a high-level overview, especially pertaining to the work we've done over the past 5 or 6 weeks to prepare for this. But part of the One Big Beautiful Bill Act, or H.R. 1, established a Rural Health Transformation Fund by Congress. It was a $50 billion appropriation intended to essentially transform rural health and give states opportunities to invest in areas that maybe we haven't before when it comes to rural health systems, access to care, population health, under the Make America Healthy Again kind of moniker. And I'll mention at the outset that what we had talked about before with some of the other provisions of H.R. 1, maybe curtailing federal funds in other states, Medicaid expansion states, federal match reductions, caps and limits on provider tax programs and hospital payments, those types of things. Since that does not really impact or negatively impact Wyoming, this Rural Health Transformation Program is mostly upside for the state. So it's something we're excited about. We appreciate the administration and our congressional delegation making this part of the bill, and I think it's something that's pretty unique that Wyoming could benefit from. What happened after the president signed H.R. 1 on July 4th is that the federal government and CMS obviously began designing guidance, rules, application materials for the Rural Health Transformation Fund. We got that notice of funding, the application guidance, kind of in mid-September, and it gave us a pretty compressed timeline in which to apply for these funds. That application is due on November 5th, so in 3 weeks or so. And funding award decisions are scheduled to be made by the federal government by the end of the calendar year, so in the December timeframe, potentially bleeding into January of 2026. And what we believe, based on our estimates, is that Wyoming could see between $500 and $700 million of investment over the course of 5 years. The program funding period is between 2026 and 2031, so a 5-year period. And there's 2 tranches of funding. One for any state that has an approved application. So that's the first threshold. The application must be approved. Half of that $50 billion is allocated equitably to those approved states based on factors like their rural health population, et cetera. And that would essentially, what we estimate is a floor of $100 million per year. So again, that's where the floor of $500 million over 5 years comes from. But the second tranche of funding is really more competitive in terms of the quality of the state's application, the initiatives and investment strategies within the guidance and within the allowed parameters that the state comes up with, scored by the federal government, scored by CMS, Centers for Medicare and Medicaid Services. And so we believe that with a quality application, we could see well over the $500 million funding over the 5 years, and potentially, upwards of $600, $700, even $800 million. Time will tell. We don't know those numbers yet. But what we decided to do when that application guidance came out in September, we didn't want to create an application in a vacuum. And working closely with Governor Gordon and his staff, one of our priorities was to make sure we got out to rural communities in Wyoming for public input, both from members of the public and from folks who work or adjacent to the healthcare industry. So we hit several different places in person, specific rural communities. We went to Newcastle, we went to Wheatland, we went to Powell, we went to Buffalo, Lander, also Riverton, Evanston, Saratoga, and Laramie. And we also had held 3 virtual town hall meetings for folks that might not have been able to attend those in-person meetings. And the feedback and public input was very good. We structured it in a way that was less about the wish list of things that people want and more about what are the core priorities, the critical services that if you were going to move to a rural town in Wyoming, what are the things that would be at the top of your list to have access to? But also, what are the things in your current community that are working well that could potentially be sustained or scaled with different investment strategies potentially supported by this fund? And I have to commend the members of the public, folks from the provider community that showed up to these meetings and really engaged, outside of their personal bias, outside of their personal industry they might work in. And we really started to see some coalescing around some specific priorities around emergency care being available at hospitals, including OB and maternity, labor and delivery care, functioning and timely and quality ambulances, EMS services, behavioral health and primary care, and also critically, workforce, just the people, as we've been talking about in a lot of different contexts with this subcommittee, access to the workforce and the pipeline of workforce in Wyoming is a huge priority for folks in our rural communities. So long story short, I think the public engagement over the past 5 weeks has gone very well. We're deep into kind of preparing the contents of the application, both in terms of the research and data to support the priorities that we will select, informed by not only the public input, but we sent specific engagement letters to various health organizations and associations to solicit their ideas and proposals for investments that they believe could be part of this overall program. But it really is an exercise in prioritization, because some of the guidance really is specific on this cannot be used to increase reimbursement rates for services that are already covered either by Medicaid or Medicare or private insurance. And I think for us, some of the lessons learned from the federal funding that came down during the years of the pandemic is to avoid these fiscal cliffs. You invest in these services, programs, infrastructure, and then the 5-year funding period expires and you say, now what? And hey, legislature, you should fund these things. And we're really trying to avoid that and create either true one-time investments or sustainable models going into the future beyond the 5-year period, where some of this infrastructure and some of these critical services that the public is giving us feedback on could be sustained well beyond the 5 years and hopefully in perpetuity. So we're preparing the application. We hope to submit a very quality product by the deadline or before the deadline. And like I said, Mr. Chairman, the funding decisions are scheduled to be made in the month of December. And we'll absolutely keep this committee and our legislature involved and up to speed on where we are. But make no mistake, this was in true federal government fashion, a rapid time cycle that we certainly want to hit. But I have to commend our congressional delegation, our governor's office, folks that worked to make this an opportunity. I do think it's some unique upside for Wyoming, something that we're excited about to really transform in a few ways how we pay for some elements of rural health and invest in Wyoming's future in a really good way. And with that, Mr. Chairman, I'll close by saying I think we have another day or two left. In addition to those meetings and virtual meetings that we hosted, we have an online survey that's on our website that we encourage folks to take. The response rate has been really good. I think we're hundreds, if not thousands, of responses to specific questions where we're asking people to rank priorities and pick between kind of the job that we have to do. What's more important to timely functioning ambulance system or maternity care, and trying to get some quantification behind the public input there. So the survey is active. It's live on our website. There's a link and a QR code that folks can go check out right on the landing page of the Department of Health website, and really encourage that participation. But a very unique opportunity for Wyoming, and something that I've engaged quite a bit as Mr. Springer has as well, with our federal partners in RFK and Dr. Oz's shop. His staff and deputies have been very helpful. The shutdown's a little challenging because some folks are not working right now at the federal level, but the engagement with health directors and the Q&A and the FAQs we've found to be very helpful, and we're optimistic that Wyoming will submit a quality product and potentially benefit from these funds, but in a very prudent, thoughtful, and conservative way, where we're not setting ourselves up for long-term obligations that we cannot sustain.
You mentioned that there are restrictions on how this money can and can't be spent. You mentioned infrastructure. Could you maybe elaborate a little bit on what types of infrastructure? We can't use this money for rate reimbursements, you said. What are the leading ideas about where this money might go, if you would?
Mr. Chairman, great question. So a few of the restrictions, I mentioned one on reimbursement rates. We're obviously avoiding that. This is not something where we would, supplant state money to increase reimbursement rates. Again, likely not allowed, and part of the guidance really restricting that. Secondly, new facility construction, so capital construction of new facilities, generally is listed as not allowable. But there are some parameters within, right sizing of certain facilities. So, conversion of, primary care space to federally qualified health centers that have a more sustainable funding model, based on patient population in long-term care settings, for example, maybe some physical plant modifications from double occupancy to single occupancy rooms. That type of investment, there are some allowances for capital construction, but generally speaking, disallowed from essentially building new facilities, which again makes sense. If you build a new facility and there's, you can't sustain it beyond the 5-year funding period, then that would not be allowed. In addition, there's some infrastructure items, broadband investment there's a big telehealth priority in the rural health transformation and technology priority in this program, but essentially, investing in the infrastructure of broadband or that type of connectivity not allowed. So you have to think creatively around other mechanisms to invest there. And I think, Mr. Chairman, I'll round out my comments by saying workforce is a big priority area in the application guidance, and something that I think Wyoming struggles with in a unique way, similar to other rural and frontier states, where quite frankly, as much work that is done on building the pipeline through our university and our community colleges to train and build health workforce, there's bigger, higher volume markets peripherally to Wyoming, whether that's out west or up north or down south or out east, and the outmigration of our young professionals, and that's not unique to the health industry, is a big problem. So we're looking at sustainable options for potentially building loan repayment and scholarship programs. We have nothing final yet. We'll work with the governor on those final priorities that we select for the application. But one big element that I think would really be beneficial to the state is if we could come up with a financial mechanism that the federal government would allow, that allows us potentially not to race to spend all of these funds every year, because it is a vast amount of money, and look at potentially investing or endowing those funds that we could accrue benefits or returns in perpetuity specific to the priority areas that we select. That's a bit uncertain right now at the federal level if that would be allowed, but I think that financial model is something that I know the folks we've talked to in our public meetings, some provider associations, my discussions with federal officials, and certainly with Governor Gordon and his staff. It is an absolutely interesting model to explore, and could really be the transformative for the investments in rural healthcare if it were allowed. And that's something that we're looking into as a potential option for these funds, largely to avoid those fiscal cliffs that I mentioned, but also that amount of money that fast can have an inflationary pressure on the economy as well. And so we're very sensitive to some of those things.
Thank you. That's reassuring. Representative Sherwood.
Thank you, Mr. Chairman. Oh my gosh, I love that idea. Um, of Yeah, if there's something that we can do as a legislative body in those conversations with our congressional delegation, please let us know. But I initially raised my hand because I wanted to share with you two things. The constituents who were able to go to that listening session here in Laramie that I heard from, they're like, oh my God, that was so fun. So whatever you did for process, like people showed up for a public meeting and had fun. So congratulations. The second thing on the survey was the bonus question at the end is quite popular. So if anybody on the call, anybody listening hasn't done it yet, it's a quick little, this or that ranking, and then when you get to the end, it's a fun little trivia question.
Mr. Chairman, Representative Sherwood, thanks for those comments. And just for the group's edification, we tried to come up with something. We want the survey to be inclusive, but we also wanted to have something that indicated, was this person, without collecting personal information, is this person likely from Wyoming? So the last question at the end is fun, but also makes you identify something that everyone in Wyoming should probably know. And it gives us a little data point to say, all right, this is likely someone who has either lived here or is from here. So yeah, I'm glad to hear the feedback of the public meetings. Largely, the feedback's been positive coming to my desk, but I do want to be transparent and clear. We did not have the time or the opportunity to get to every community we wanted to, just given the compressed timeline. But I really owe a debt of gratitude to my staff, including the folks on this call, but especially our Deputy Director, Franz Fuchs, and our Medicaid Medical Director, Dr. Tracy Haas, our Governor's Office, for making this a priority and getting out to as many places as we could. I think given the timeline, it's been a good process.
So Director, if you'd take a moment and remind anybody on here, or maybe they missed it before, where can you find this survey?
Absolutely, Mr. Chairman. If you go to health.wyo.gov, that's just the landing page of our Department of Health website. There's a big box that says Rural Health Transformation Plan. You click on that icon, and the first thing you'll see is a box that has a link to click or a QR code to scan. If you're using a mobile device, you can get the survey. You can get the survey there. And it looks like Jesse also posted it in the chat here in the Zoom.
Thank you, gentlemen. Any other questions from committee? Yes, Senator Larson.
Yes, Mr. Chairman, thank you. I missed the meeting in Powell. I'm sorry I did. I was out of town, but I haven't been in running around town that much to hear how it went. I hope it went well. I'm excited to hear some of the things you discussed. The telehealth issue. I hope that helps. I would guess that would help our hospitals a lot, and hopefully, I don't know what that might mean. If that means you got the little units running around in the hospital so the doctor can do it better, or runs into the room better. I don't know, but that's interesting. And training labor force obviously is important, and excited to hear maybe a loan repayment or scholarships might be available, maybe kind of like we're doing with our doctors.
Well, and Mr. Chairman, Senator Larson, I appreciate those comments specific to the workforce. It's been a big topic of discussion in the public meetings, and certainly with our partners in the industry of healthcare here, where I do think we've done some investigative work with our university and community colleges of what's the capacity to scale up, family practice residency slots, or seats at a community college for nursing or mental health techs or CNAs, to look at, even if it were one-time investments that didn't happen beyond the funding period of this grant. If you spent 5 years, incentivizing folks to join this workforce and make it worth their while, but also get selfish on the back end with retention mechanisms for here's how long you would have to stay in Wyoming and demonstrate that. I think there's, even if our ideas to finance these things in perpetuity were not approved at the federal level, there's really good benefits for investing in those types of things, or at least scaling them up briefly, because you would accrue that benefit of having the workforce potentially for 5, 10, 15 years after the funding period ran out. So there's a lot of upside here for Wyoming, but I do want to be clear for the members of the public that are listening. this is an exercise in prioritization. So we're not going to make everybody happy with the ultimate application. And that's kind of the nature of the beast in taking everything we've heard, all of the good ideas, all of the investment proposals, and really picking the top line priorities of where critical investment is needed. And that comes at the expense of some really good ideas. So we appreciate everybody's feedback, and certainly you all in the legislature over the past 6 weeks helping us get the word out. And the attendance was really good in most places. And like I said, the feedback was very important to us.
Speaking of feedback, is there any public comment remaining on the Rural Health Transformation Fund? I see none. Going once, twice.
No public comment.
All right. Let's take about 15 minutes and do whatever it is that you need to do, get it out of the way. And when we come back, we'll look at workforce challenges and opportunities and wrap this thing up.
Mr. Chairman,
See you.
sorry.
Yes.
Last minute. There's one person
Oh, okay.
on Zoom who had their hand up.
Mr. Chairman, we're admitting former Representative Sweeney now.
Okay. Welcome, Mr. Sweeney. It's good to see you again.
Good to see you. Thank you, Mr. Chairman. Pat Sweeney from Casper. So I attended one of the virtual meetings, and the director and Franz did a masterful job, I felt. And I don't know if I'd classify the virtual one as fun, but it was really, really good, and a lot of good dialogue. Mr. Chairman, one of the things that I've been wondering, well, a couple of things I've been wondering about, I brought up a conversation during the virtual of, there's been long talk for years and years of setting up our own kind of, I'll use Medicaid, but not Medicaid, but a frontier, I think years ago was dubbed frontier healthcare, like an insurance program. But at that point, both the director and Franz didn't feel it would fit into the modeling for this. But I don't know if anything different has changed. The other couple of things I was curious about, I appreciate the director talking about the nursing training, and could there possibly be monies carved out long-term, possibly for not only the WWAMI program that possibly might move to Utah, utilizing Utah versus Washington State with the WWAMI program. And then further, there was talk quite a few years ago, well, not that long ago, but about trying to set up at the University of Wyoming a physician's assistant program, which could be really valuable within Wyoming. Do any of those things, Mr. Chairman, fit the model? And I only pose that as a question. I know typically you're not supposed to ask questions, but if that could be part of the thought process for a future meeting, the director will probably answer no, no, and no. But
well, let's give the director the opportunity.
Thank you, Mr. Chairman.
Yep.
Well, thank you, Mr. Chairman. And the simple answer is yes. That has been a part of our, both with WWAMI, with the family practice residencies, with WICHE, and with out-of-state or neighboring state medical schools, actually participating, sending some folks out with others to the University of Utah to look at what potential slots could look like for Wyoming to have in that medical school, and whether or not that would connect to this funding opportunity. But former Representative Sweeney, I will say that both with those programs that I mentioned and our, which I think are very important, our community college programs and other training opportunities in the health industry, we're looking at anything and everything to look at investment in scholarships, in training and loan repayment for those specific workforce development programs that already exist that we could potentially scale temporarily during the funding period, or again, if endowed, maybe beyond the funding period at a lower level each year, but in perpetuity. That those are things that we're absolutely looking at, and I think all of those options are on the table. Met with during this rapid process with folks at the university and our dean of the College of Health Sciences, our community colleges and their commission. So we've done as much legwork and outreach as we can to determine, at least initially, what could be what out of those programs could be scaled, what capacity they have to scale up. And so without getting ahead of my skis on what the final application will look like, I think those workforce items will likely very much be a part of it. And Mr. Chairman, if I can, I'll just take the opportunity to mention kind of the application structure here. And this is also a challenge, but I think we'll get to a good quality product. We're limited in our page numbers by CMS in our application. They don't want more than 60 pages in this application. So essentially what that means is we'll be taking broad categories within the allowed parameters and essentially proposing a cost allocation methodology. For example, Wyoming proposes 15% of its award going to this broader workforce category, 20% of its award going to provider payments in this new payment model for EMS or hospital-based maternity care or whatever those ultimate priorities might be. And then on the back end, if we were approved and then allocated the whatever the award amount is, then we would turn around as a department more in a procurement sense and be reaching back out to those stakeholders, in this case, educational institutions, and that to see who would want to partner on these, innovative ideas of what would be trying to scale up. So that would happen to start in the first part of 2026 if we see an approval and if we see an award allocated. So hopefully that's helpful. I know folks have been a little bit nervous, thinking, my goodness, are we going to have all the specifics of spending $500 million within the next 2 weeks? And the answer to that is no. We're really trying to develop what those priorities would be in kind of a cost allocation methodology that would govern where those investments would go. And then we get specific in the purchasing and procurement and partnerships after we see that, hopefully after we see that approval.
Mr. Sweeney, do you have a follow-up?
That sounds terrific, and I really appreciate the director's thought process on all of that, as I'm sure the committee does too. One final was you left out the Frontier Insurance thought process. Just was curious on that, Stephen.
Director?
Mr. Chairman, it's an interesting question. I don't have any specifics on whether that will be part of a proposal or whether it would be allowed. We did get a lot of public feedback, as I mentioned before, on these potentially expiring, enhanced subsidies on the marketplace. And that did seem to be, at least from the community feedback we received, a concern that was of some priority. What mechanisms we would have to offer an alternative, we're reviewing that and reviewing its feasibility as potential part of this application, but nothing final on that yet. We'll be, working hand in hand with Governor Gordon to over the next couple of weeks as we finalize the application, and happy to loop back with you after that if that does end up being a part of it.
All right.
Thank you, Mr. Chairman.
Thank you for being with us.
Give the director a raise. So
I would at least give him a thank you note.
Yes, indeed.
All
Thank
right.
you, Mr. Chairman.
Has anyone else popped in to opine?
No, Mr. Chairman, we've not seen anyone else jump up here in the room nor online.
All right. Let's take that break that we have so bravely earned. We'll come back at 3:05. I don't want to deprive anybody of any time. 3:05. We are at that allotted time to resume the meeting and close this one out. I do want to say thank you to Director Johansson and his crew. You guys have been terrific. It's been a pleasure. Looking ahead here, workforce challenges and opportunities. Anxious to hear what opportunities you see and how that works in. I know that the challenges are substantial, and not just in the Department of Health, but all across the state. So without any further ado, take us ahead.
Thank you, Mr. Chairman. I'll just briefly echo my previous sentiments about what this rural health transformation program opportunity could mean for health workforce in Wyoming. So we're taking a hard look at that, potentially incorporating that into our application to the federal government for investments that could really build, especially our rural and frontier areas with the workforce that we know in certain priority areas is desperately needed. I'll be selfish in a minute and talk about our workforce challenges at the Department of Health facilities and field offices, but I do want to be clear that we're not unique. We're not a special snowflake in terms of the healthcare industry that also struggles with access to labor and adequate number of providers, whether you're talking about long-term care facilities or hospitals or primary care clinics, just runs the gamut of especially entry-level workforce. It's just it's been more difficult in recent years to come by. It does seem like there's some light at the end of the tunnel of things improving. In the industry, at least, a little bit less reliance on expensive contract labor. Not everywhere, but in some places that market has improved. But pivoting to the state facilities, because I know it's been a hot topic with a number of committees this year, including Joint Judiciary, who we met with yesterday, talking about a specific issue with availability of state hospital beds for law enforcement and long wait lists for Title VII and Title 25 populations. That has just been a perennial problem for us to have the adequate workforce at a real constitutionally established safety net facility, core critical work that we do in the Department of Health. And the state hospital does an excellent job, but it's just limited by the availability of entry-level nurses and CNAs and other workforce that keeps us from operating that facility at full capacity. I know it's often irritating to hear the director of one of the biggest agencies in terms of budget come and say it's all about money. And it isn't, but it's a big factor when it comes to what we pay competitively for certain types of positions in the department. And my focus, especially over the past several years, is not about all of the workforce of the Department of Health, which is obviously important, but specifically our direct care settings, our 24/7 facilities, and our public health and public health nursing and WIC field offices. It's just been an immense challenge to keep those facilities and those offices staffed up. A few just data points to highlight, Mr. Chairman, for CNAs at the Department of Health facilities. At the Life Resource Center, I am about 65% vacant on CNAs and what we call DSPs, your entry-level direct care professionals. At the Retirement Center with CNAs, the Retirement Center in Basin, we're currently 58% vacant on CNAs. At the Veterans Home, 20% vacant on CNAs, and 50% vacant at the Veterans Home, the new nursing facility there. And at the state hospital, again, here's some optimistic news. Our team there, in terms of our administrator, Christy Barker, and our director of nursing, Dan Johnson, done a lot of work to build up our entry-level CNAs and our recruitment over the past year, hitting the pavement, partnering with community colleges, the university, colleges outside of Wyoming to host clinicals and get folks into the state hospital, see the really amazing work that we do and the new facility that we have. And our CNA vacancy rate for entry-level CNAs has dropped from over 50% a little more than a year ago to under 17% today. So outside of money, that's really my point, is we can do good work in building a better culture, investing in our staff and their education, showing them a pathway of career advancement. And the state hospital has really taken the bull by the horns trying to do those things over the last year. However, On the nursing side, we are still 40% vacant at the state hospital in terms of state nurses. We at the Veterans Home, 56% vacant on nurses. At the Retirement Center, 70% vacant on nurses. And at the Life Resource Center, 58% vacant on nurses. I give you all those facts and figures to really lead to one important point, which is the reason when we have all of those vacancies, and in this case, a couple hundred vacancies of those positions at the Department of Health's budget, what we do in order to preserve a limited bed capacity that we have for our courts, for our hospitals, for our county detention centers and jails, is we take that vacancy savings and we contract for more expensive agency labor, traveling nurses, traveling CNAs. And it can't be a one-to-one because the budget for those salaries for a nurse, as an example, is $31 to $33 an hour, but it costs us $75 an hour to buy a contract nurse. So we take those vacancy savings, we pool them. As my CFO will tell you, it's almost a one-to-one, almost 100% of those vacancy savings goes to this endeavor, which is to try to keep as much bed capacity open as we can for the customers that we serve, like our judges, like our county attorneys, like our sheriffs. But it is becoming, it's becoming unsustainable. I appreciate this committee, the Judiciary Committee, the good discussions we're having about what should that long-term investment look like? Because ideally, we would want, much less expensive state staff to occupy those positions and to keep those beds open and operational. And it does take investment up front, but long-term, I think we could eliminate a lot of contract labor that we're on track this year to spend upwards of $17 million on contract labor. It's an absolutely massive expenditure that annoys your health director maybe more than any other operational challenge in the Department of Health. It's a tough decision for me because while I could make the decision tomorrow to cancel and say we are not buying any more contract staff, we could do that. But what it would result in is an even longer wait time right now for our sheriffs, even longer wait time for our judges, for our county attorneys, and we haven't made the decision to do that. But I anticipate and would be absolutely happy to participate in discussions about changes we could make to make the Department of Health facilities slightly more competitive, get Wyoming people into those jobs as opposed to out-of-state contractors. But it's a difficult issue, but one that I'm optimistic we're moving in the right direction in.
So, Director, I'm glad you mentioned that. That's actually on my list for things to look at the next meeting in a couple of weeks. Our good friend, the senator from Campbell County, likes to talk about a self-licking ice cream. And that's kind of what we create when we hire these contract nurses. Clear back 25 years ago when I was around that business, a lot of nurses were saying, hey, if you want to make the money, you go into the traveling deal. That's the gig. That's where the money's at. So there has to be a sweet spot. And I guess that's what I would ask us to look at over the next couple of weeks, try to get closer toward. We know that if we sweeten the pot for new nurses, that we also have to retain the ones we already have. And so there's that initial cost outlay. Somewhere there's a sweet spot where you say, if we could settle in at this, and I guess I would like to explore that in a couple of weeks. Where might that spot be? How much would we have to pay so that we're not creating our own vicious, chasing our tail and creating more of a problem there? So before you comment, Representative Sherwood.
Thank you. I just wasn't writing fast enough. What did you say the average wage was for that entry level compared to that $75 an hour when we contract?
Director.
Mr. Chairman, thank you. Representative Sherwood. So two categories, I'll give you both. For entry-level nurses across the Department of Health facilities, what I can offer right now is $31 to $33 an hour. And our contract rates for nurses right now is essentially buying the same position on a 13-week assignment or longer is anywhere between $70 and $80 an hour, depending on the contract. I have a lot of contracts executed. We use them as needed. so that we have multiple options. But there's usually a few firms that each of my facilities will work with more prominently. So that's for nurses. For CNAs, so your entry-level direct care, I can pay anywhere from $17.90 to $17.90 to $18.90 per hour starting. And our contract CNAs, when we have to procure them, are running us anywhere from $45 to $50 an hour. So again, the contract agency takes their cut and obviously pays, as Representative Pendergraft was rightly mentioning, is certainly paying that employee more than what their counterparts that they're working with on the floor are making, but also taking that cut off the top. And it's an absolutely apt metaphor on the self-licking ice cream cone. And it's also, I'll put it this way, it has this effect of cannibalizing your own staff.
Yeah.
And I have very good, direct care staff at some of my facilities that have been working under contract, for 1 year, 2 years, even 3 years. And so we're looking at provisions to, restrict radius. If you live nearby and you've been on contract for this long, then we're likely going to turn that off. But again, those decisions come with consequences of, maybe that person just walks because the traveling gig is so much more lucrative. But at a certain point, we've got to make that decision because it's unsustainable for the state finances. And so those are difficult decisions. But Chairman Pendergraft, I agree with your sentiment that there is a sweet spot that is far, far, far below the $75 an hour for a nurse. And our market data and research suggests that it's somewhere around 39 or 40 for that entry level nurse right now, which again, with the investment you mentioned for retaining the staff that have stayed with you, in addition to taking up the recruitment in an equitable way, I do think long term it would pan out as a benefit for the state. I don't want to sound like a used car salesman that's saying invest in the rust coating now and you'll save all this money later. But the amount of funding that we could potentially offset and help in that investment for state salaries at a reasonable rate. And again, we don't want to outcompete local communities and their other healthcare institutions or facilities, but at the same time, these are small towns, and we just deal with that labor force fluctuation and are often in these competitive situations. The difference with the state facilities is we have pivoted, especially over the last 5 years or so, to really adopt this safety net mentality, not just at the state hospital, but with the Life Resource Center. Their mission is to serve state hospital discharges and emergency cases and folks that can't be served in other settings around the state. Retirement Center is the same way. We take involuntary discharges from other nursing homes that can't be served there because of their behaviors. Discharges from the state hospital for folks with sexual histories, criminal histories that other nursing facilities either can't or won't accept. We've really tried to pivot to that safety net mentality to really justify why do these state facilities exist. And I think that that does make those facilities a bit unique, and also makes the environment in working in those facilities unique for the staff and the type of clientele they're serving. But I just want to be sincere in my comments here that at the very least, I appreciate this committee and other committees' discussion on it. There's no easy answers here, and money's not going to solve all of these problems. Money and state salaries is not going to solve the wait list problem for Title 25 and Title 7 at the state hospital. It will help, but that's why we've really tried to also build up and invest in these other initiatives with the judiciary, with our jails and sheriffs, to partner to do things better, to look at different ways of community resources coming into jails and serving these priority populations with programs we already have. So all of those things working in concert, I think, give us a model in Wyoming that shows good promise. But yeah, some tough decisions on the investment side of how do you keep these facilities not only sustainable, but doing their job to serve the state, to serve law enforcement, to serve the courts, to serve our hospital emergency departments. It's a tall order, but again, Mr. Chairman, I really just appreciate you all being receptive to the discussion and putting our thinking caps on to try to find a better solution than the massive amount of investment we're making with contract agencies.
So you met yesterday with judiciary, and I, for one, I saw a little bit of it, but haven't had a chance to go back and review that. I felt like I ought to be better prepared for today for some reason. Probably a lot of people listening don't know exactly what happened. Would you be able to give us just a couple of minutes, a thumbnail of the discussion you had with judiciary and where you think that's headed?
Mr. Chairman, I'm happy to. So Judiciary was considering a bill draft that provides a statutory structure for the Department of Health to reimburse county detention centers, county jails, for holding Title VII detainees. So these are folks that are waiting admission to the state hospital. Similar to Title 25, whereas you might know the department is responsible for all costs of Title 25 after the first 72 hours of detention. So we pay designated hospitals, other hospital emergency departments, kind of on a fee schedule or a per diem for holding and treating Title 25 clients that are committed to the state hospital. There has been and there is no statutory structure to do the same for jails and sheriff's offices under Title VII, which is the criminal forensic statutes. So these are folks that, for whatever reason have been charged with or convicted of a crime, and the judge has ordered them to be served and restored at the state hospital to either come face, be restored and be able to stand trial for their crimes, or in certain cases, adjudicated not guilty by reason of mental illness and committed to the state hospital for treatment. That inpatient wait list is quite lengthy, about 4 to 6 months for admission to the state hospital. Again, limited by the number of beds and the staffing we have available, but also, there's the order volume over time has just increased from the judicial system. So what that bill would do, in addition to allowing us to reimburse, just for the holding and detention, is through a partnership with WASCOP and numerous county sheriffs that has been really, really productive over the past year. We came up with kind of a joint proposal that potentially allowing the department to reimburse on a tiered structure. So yes, security and detention, we could reimburse, offset some of the jail costs for that. But for those sheriffs and jails that are interested in partnering with us on more active treatment, medication administration to stabilize those very, very sick psychiatric clients faster, potentially reimbursing at a higher level for those types of outcomes that we all want, and really trying to benefit the broader system, reducing these wait times, reducing the jail staffing burden, reducing the burden on the state hospital, and ultimately serving these clients in a faster and more humane way. Again, connecting to the past few years of reform and new initiatives we've had to connect our community mental health resources more to this population, to partner with the judiciary to divert low-level criminals out of this criminal justice cycle and into community treatment. Investments that are already there, budgets that are already there. And that discussion, Mr. Chairman, at Judiciary led to what we're talking about today, which is what is the status of your staffing, recruitment, and retention at the state hospital. And again, I felt similar sentiments of, man, we got to figure something out here because this is unsustainable, the amount of money we're spending on contract labor. So it's a connected piece of the overall issue, but one that I think if you talk to your county sheriff, your jail administrator, as much as they might want to throw stones at me, and I don't blame them because the wait times are quite lengthy right now, they'll probably have a lot of complaints about the Department of Health and the state hospital and those timelines. I think almost universally you would hear, but they need the resources to be able to operate at full capacity. And that would benefit us at the county level, benefit us at the law enforcement level. And so long story short, Mr. Chairman, I'm very thankful, as I was yesterday, to Judiciary for the ongoing dialogue, the numerous meetings we've had with so many interested and participating sheriffs who we're trying to work together on this thing and come up with mutually beneficial solutions. And excited to see how that bill and that discussion fares as we go into the legislative session.
One more layer to the onion, and I don't know whether you can speak to this or not, but we have issues with both the boys' school in Orland and the girls' school here in Sheridan. They are housing people that they are not necessarily qualified to accept because of backlogs and other things. Are you able to comment on that, how this figures in?
Mr. Chairman, I would absolutely defer that to my colleague and good friend, Director Schmidt with Department of Family Services. But I will say at a high level, I know she shares our concerns and vice versa, that operating facilities like that your patient population results from court orders. You don't have a lot of ability to say no. It's very similar to, our plight at the state hospital, where we're trying to serve a safety net clientele, and it becomes very challenging with access to, appropriate labor and people to staff those facilities. So I know that in the broader discussion about this type of state employee compensation with folks that are working in 24/7, safety net facility environments, without speaking for Director Schmidt, I would say that I would anticipate she would harbor the same kinds of sentiments, that we're trying to operate those facilities at the highest capacity we can to serve the customers that we have. But the challenges with staffing are immense, especially given the settings that those staff work in and do excellent work. So just a high level comment, but I'm sure in future meetings or discussions, Director Schmidt could shed a lot more light on those two facilities than I could.
Thank you for that. Any other comments from either Ms. Bicker or where'd he go?
Mr. Chairman, yes.
Go ahead, Mr. Bicker.
Yeah, just really quick. My background before I came to work for the state, I worked for a large hospital provider for about 20 years. So I ran hospitals. I was also a chief financial officer for hospitals. And anything that I'm going to tell you right now, I'm sure you're going to know. But a couple of things I wanted to highlight. One, the director hit on having employees who work for us, nursing staff, direct care, that are working for us at the rate that we pay them. And then we bring in these, temporary travelers, and they're making 3 times as much. It's a huge morale issue. And I give a lot of credit to our state employees who stick it out and do a great job. And the other thing I would say is, my experience shows that the travelers, when you get them in, they just, because of the nature of, the traveling work, they don't buy in as much as your employees that are on staff, and into your culture and into the things that you're trying to do at the facility. So it's a broken record. I don't have any easy answers, but I thought I would add that. And also, we're in a unique situation from hospitals that I used to run, is the safety net feature that we have. So in other hospitals, we'd say, hey, we're just not going to do traveling nurses anymore, and we'll just scale down to whatever we have the staff to do. That's really, it is an option, but not a great option for us because of the safety net nature. There's nowhere else for a lot of these people to go. And so we're the last that take them in some real vulnerable type situations. So my 2 cents on the traveler versus state employed direct care providers. Thank you.
Thank you, sir. I find it a little bit personally dismaying that, this was a big issue 25 years ago when I was there, and it still is. And I guess there's a part of me, I'm a mechanic by trade. I'm a remodeler. I see something broken, I want to fix it. And this is obviously something that is a tremendous challenge. So let's do what we can to see what we can find. Mr. Springer, anything that you would care to add?
No, thank you.
All right then. Anything else that we have left off before we go to public comment, Director?
Mr. Chairman, no, just once again, just like in Casper, thank all 3 of you for your time. I know it's a big elephant to start to chew on. And I've worked with this department since 2013 and learn something new every week, and it's very complex, but I appreciate the diligence. And like I said, just your receptiveness to some of our perspectives on these challenges, and committed to, in big discussions about the Department of Health budget, which are not easy. I hope you have what I think to be a very objective and data-driven resource in the Department of Health to help you with decisions. And it's something we try to bring dispassionately to. There's a lot of passion out there in healthcare and Department of Health budget, but the reason we talked about our strategic plan, the various studies we've done, our health stat performance management data, When those decisions come to you all or come to the JAC or come to the legislature, you certainly have the Department of Health as a resource to look at how is that function performing, how have the finances looked over the past several years, what outcomes are we hitting, what outcomes are we not hitting. So please feel free to lean on us for those types of requests as we go forward into the fall. But thank you very much, Mr. Chairman, for your time.
I think it's important to point out that when we started this process, we didn't come here operating under the delusion that we were going to solve everything in 4 weeks' time. But as you alluded to, there's a way to eat an elephant, and it's one bite at a time. And I can't simply stand back and say, golly, there's a big problem there, but I'm not going to at least go in swinging. So that's what we're here for. I appreciate your cooperation. I very much look forward to the discussion, which we'll get here in just a minute, about what to handle in a couple of weeks or what to look at. But before we do that, we do have a space for public comment. If there is anyone online or in the room who would like to comment on this particular topic. Anybody there?
Mr. Chairman, we have no public comment in the room or online.
Okay, I can barely hear you, but I believe that you said there was no public comment.
Yes, Mr. Chairman.
All right, thank you. Move on then to committee directives. We just spoke of one, which I think I'll just kind of reiterate at the top of this, is what I would call, where's that nursing pay sweet spot? You know, we're going to have to look at how it balances out. How do we maybe sweeten the pot for those that are here locally to where we don't have to depend on the outside help at an exorbitant rate. So if you guys could maybe put together some ideas on that. I know we've touched around the edges. Somebody that could crunch some math. I think you probably got at least one person in this room that's pretty good at math. Really better than I am. Anyway, that would be the first thing. Representative Sherwood, I believe you had something you wanted to look at.
Thank you, Mr. Chairman. Yeah, I think I'm just interested in learning more about the health stat, not necessarily going all the way back to, I think it was 2011 when it was established, but maybe reviewing the most recent report, which I think is from 2024 or whatever you might be seeing ahead of that, just so that we're more knowledgeable about that as a resource and how you guys utilize it, so we can speak more knowledgeably just about the ways that you're continually finding efficiencies and measuring and metrics and all of that fun performance stuff. Empowering us to really understand how you use that tool would be helpful.
Okay. Any of you need any clarification on either of those topics at this point?
No, Mr. Chairman, relatively clear. We already have a lot of data and numbers crunched on the salary side, and very thankful to our partners at Department of A&I for, they're very well aware of these challenges as well and have worked with us on certain flexibilities, also longer term proposals of especially this direct care staffing issue that we have. So happy to prepare that and customize anything for this committee that would be helpful. And to Representative Sherwood's point, anytime anybody, this committee or otherwise, wants to talk about health stat, I am at the table. It's one of my passions with this department, is focusing on that performance. So I'll shoot, in addition to some other resources you all asked for during this meeting, I'll shoot you guys the most recent health stat final report. Spoiler alert, it's lengthy. We intend it more as a reference document. You can reference certain programs or look them up, but everything's in the same format and kind of the same value chain. But I'll shoot that over in anticipation of the next meeting as well.
Thank you. Senator Larson.
Yes, Mr. Chairman, thank you. Obviously, I'm interested in on the director of A&I. Would it be helpful to have him at the next meeting, you think, in any way to help on what they may say? I don't know. just a question I wanted to throw out there. Also, obviously it's important on your next budget, but I know you can't tell us very much until the governor actually puts out what his recommendations are, but that's so important. But I really don't have any other asks. Both of the ones that were stated are vital.
Okay. I would like to offer a third, which I have mentioned to LSO earlier, and I alluded to it here, going back to looking to rein in any kind of abuses, and how do we protect ourselves from waste, fraud, and abuse? The data collection, how do we screen, a little closer look at how we screen applicants, cross-checking, do they simply make an attestation and we accept them at that, or how do those things go together? Again, my primary purpose there would be if we've got people who are accessing funds illegitimately, we want to cut them off and preserve that money for those that actually do need it. And so I would make that as the third item. And I believe those are everything that we had. Go ahead, Representative Sherwood.
Thank you. I think this is maybe even just a quick 1 or 2 sentence memo, maybe, but really looking at the number for the new policy around the payment error rate. My understanding is that, so like if we're 1% above that 3% threshold, that could translate to like $3 million, but my math could be wrong. So I think just having that calculation of like, okay, we're asking for more positions so that we are efficient and stay under that 3% rate. What would that budget look like compared to, for every 1% we would be over, how much we would lose in federal funds? So maybe that's just a quick table that we can have at our disposal. Thank you.
Kind of files under the ounce of prevention's worth a pound of cure.
Mr. Chairman, no concerns on any of those topics.
Okay.
We'll do our best to prepare materials for you on all three.
Now you gentlemen, you're full-time, you do this all the time, you've been doing it for a long time. I would ask you for a moment, put yourself in our shoes. Is there something that you think we ought to take a look at that we don't, you don't know what you don't know? Is there something we need to be aware of that we haven't asked for?
Mr. Chairman, a couple of months ago, prior to July 4th, I would have said, let's pay strict attention to HR 1, big beautiful bill, changes to Medicaid that might come from that. I think we've done a good job, thoroughly vetting and discussing how a lot of those provisions won't impact the Department of Health. But I do think this Rural Health Transformation Program is a big opportunity. I appreciate the agenda time today to discuss it. We're more than happy to keep the committee in the loop and engaged and get feedback on how we're progressing and certainly, if approved, how we're implementing going into next year. So that would definitely be a priority item. You've been gracious enough to discuss and be very thoughtful about our facility staffing issues and some of those key priority areas. That was definitely one on my list as well. But in terms of our department's operations, nothing else comes to mind. I think the agenda items you've hit today, preparing both this subcommittee and us, frankly, and the public for what to expect going into the next budget hearing and legislative session, I think has been very important. So appreciate the time you've dedicated to that.
Thank you. This thing started, as we all know, with a discussion. Well, it really didn't start there, but that was the spark. The discussion over the DD waivers, and there's also, community waivers that are in there. And I guess I would like to know some sort of a comparison looking at like the community waivers. When there's a backlog with the DD waivers, are we compensating by adding a bunch of moving them over to another type of a waiver, I guess is what I'm getting to, that maybe isn't as efficient or as effective. So that's something that I'd kind of like to look at. And then holding to that, how do we screen those applicants for waivers? Similar pattern through there. I just want to make sure that we're not creating another type of waiver that ends up becoming abused or bloated because it becomes kind of a catch-all.
And Mr. Chairman, that's a fair concern. I think we can incorporate some of that into our discussion or materials on, this eligibility and fraud, waste, and abuse overview, both in terms of Medicaid state plan and our waiver programs, because they do work hand in hand in terms of the compliance action we take, the recovery actions we take, those types of things. But I think we could probably incorporate that. And I know, at least I think that in one of the last meetings for the broader Joint Appropriations Committee, that the DD waiver item is on the agenda for a couple of hours. At least I think I've been notified of that. So certainly look forward to those discussions, and anything that we can help this subcommittee queue up. In the meantime, before the next meeting, please let me know.
All right. Any final remarks from the committee? No last words. All right. Thank you very much for your participation, and especially again to the LSO for their work. Before we close out of here, maybe we could get a little bit of a summary from LSO as to where we're at and where we're headed, what we've done today and where we're going.
Mr. Chairman, Elizabeth Martineau, Legislative Service Office. I have that we have gone through the Department of Health's 2017, 2018, 2021, and 25 previous budgets. You've had a couple of asks of the agency for particular documents that they've agreed to provide. We also looked at HR 1 today and some of those impacts that are going to be coming about, particularly with the rural healthcare transformation. And so I will add a small item with your permission to the next agenda just to have an update on that as you go through, just a couple minutes, 15 minutes to say, hey, is there anything new in development? And then you've also talked extensively this afternoon about workforce issues and trying to figure out with the department what to do. So for the next agenda, I think what we're going to try to help you accomplish is an agenda item looking at the Department of Health's discussion on nursing workforce in particular, since they have quite a bit of data and information. With your permission, and if it is within your interest, we could reach out to Director Tricia Bach with the Department of Administration and Information, as well as her HRD, or Human Resources Division administrator, who does oversee and has testified numerous times, as you know, as JAC staff or JAC members, that they've testified about those kinds of updates they have as they do look at workforce issues. So we could invite them, with your permission, to the next meeting. Then we can also do, as Representative Sherwood had requested, a health stats overview. If the Department of Health was so inclined, they may be even able to show you some of those pages as they discuss those, to kind of give you a preview of what that looks like. And then to your bigger topic, Chairman Pendergraph, looking at Medicaid as well as the waivers, for that qualifications, application, fraud, waste, and abuse kind of overview on those processes, applications, vetting processes, any auditing that there may be, as well as that Medicaid error rate. I believe that is all that I have for the agenda and for this meeting. Is there anything that I missed, sir?
No, I think that's good. I would like to expend, especially since we're meeting virtually, an invitation to ANI. They may have something to contribute, have some data available that we wouldn't otherwise have. I think other than that, I would be satisfied.
Very good. Mr. Chairman, we will extend that invitation.
All right, with nothing further, this meeting's adjourned.